Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School, and welcome back to another Computer Connect. Today I wanted to talk about the management of gastric intestinal metaplasia. It's something that we see on biopsies a lot. We have incredible disparity of how we all probably manage that, and I want to talk to you about several different aspects of how we can improve. Let's start with basics. Gastric cancer is the third leading cause of cancer and related death in the world, accounting for over 1 million incident cancers annually. In the US alone, 26,000 plus cancers. And these are typically, the majority are what we call the non-cardiac gastric cancers, arising from the antrum, the fundus, the incisura, and the body. And these are related in particular to chronic H. pylori infections, the primary risk factor. These non-cardial intestinal type gastric cancers follow a stepwise progression known as the chorea cascade, and this is something that goes from normal mucosa to gastritis to non-atrophic gastritis, atrophic gastritis, intestinal metaplasia, and then gastric adenocarcinoma. The ability to follow those people and strategize in those intestinal metaplasias to the focus of today's discussion. We do know that there's tremendous variation in the practice patterns of physicians as they relate to biopsies and management of intestinal metaplasia, in particular in the US, and in particular even in centers that may have higher relative risk factors such as increased racial or ethnicity or immigration type risk factors in cohorts that may be coming into their clinics. Well, how do we propose to address this? Let me talk about what we're probably not doing, two things. Let me focus on a couple AGA guidelines and then focus on how we can do better. What we're probably not doing. Number one, biopsy technique. The Sydney criteria, Sydney classification scheme involves a biopsy approach of two separate areas, routine biopsies in the antrum, lesser curvature, greater curvature, and the incisura. The incisura seems to be a higher incidence of gastric intestinal metaplasia and progression of dysplasia. Biopsy bottle number one. Biopsy bottle number two is in the corpus, in particular, lesser curvature, greater curvature, again, bottle number two. Any focal lesion gets separate biopsies, very analogous to what we would do in Barrett's esophagus in our surveillance strategies there. What we're probably not doing. Number two is classification by our histopathologist. This is where I think we're really falling off very dramatically. There are two validated instruments that are used for histopathologic assessment, and these portend for greater risk for progression. They're called the OLGA and the OLGIM. OLGA is the operative link for gastritis assessment, and the OLGIM is the operative link for gastric intestinal metaplasia assessment. These are validated instruments. The histopathologist could easily follow these. They rate different stages as it relates to the combined biopsies of the antrum and the fundus. So the level of involvement goes from 0 to 3 in the score, and then the relative combined score of the antrum and the perspective of the fundus or the body gets a total staging goes from 0 to 4. The staging from 3 and 4 is very important because this also has been associated with, number one, very high risk for gastric cancer, about a 21 times odds ratio greater or increased risk, and the risk is rapid, typically less than 2 years. So again, getting a histopathologist to identify these for us based on standard criteria. Again, these are very routine type of histologic assessments, H&Es, no special stains, but the histologic pathologic implications, I think, are very important to talk to your pathologist. So OLGA classification or OLGIM. Second step is, what do we do with guidelines and how do we apply guideline recommendation? The AGA put out in December of 2019 3 separate statements looking at 2 very intense technical reviews I thought were brilliant. But the guideline recommendations, number one is intestinal metaplasia, obviously treat H. pylori and document eradication if it's present. Point number 2 is in patients with gastrointestinal metaplasia, they did not recommend routine use of endoscopic surveillance. The exception perhaps may be in an informed discussion with the patient, particular if they're high risk. High risk criteria would be incomplete versus complete. This is a histologic differentiation. The incomplete is more the colonic type of gastrointestinal metaplasia, and the complete is more the small intestinal type of gastrointestinal metaplasia. It relates to brush border and goblet cells beyond today's discussion. High risk number 2 is extensive versus limited. Extensive, remember those 2 bottles that we're going to get, the antrum and then the fundus on the body. that's extensive if it's evident there versus limited. So it's just in one of those bottles. Extensive is a higher risk profile as well. Family history is a third relative high risk. The other is racial and ethnic minorities and migration from certain areas of the world. So immigrants from high incidence populations. Those patients should have potentially an individualized discussion and maybe start to look at bringing them back with some more intense evaluation. And recommendation number 3 for the practice guideline was you don't need to bring them back early if you identify intestinal metaplasia and just based on the identification of intestinal metaplasia in the absence of something that you saw with focality. How does this apply to other guidelines? Well, the American Society of Gastrointestinal Endoscopy, the ASGE, in 2015 published their guideline that said that if you have intestinal metaplasia and you have 2 sequential evaluations without progression or dysplasia, then you could disenroll those patients from surveillance, similar to what the endoscopy recommendation from the AGA and the ESGE, the European Society, said similarly, you should not necessarily have to bring these people back except if these people had higher stage, the Olga or Old Jim stage 3 to 4, we said higher risk and higher progression, rapidity of progression. Those patients should be individualized and perhaps be brought even more closely, perhaps even a 1-year interval. So again, routine recommendation for endoscopic surveillance, not necessary in the vast, if not not the total majority, but the vast majority. Okay, let's shift to how can we do better? Well, an excellent training piece which was just published in Gastroenterology, and I'll reference here by Dr. Shaw at UCSD in La Jolla, California. Couple things that I wanted to highlight. We'll start with pre-endoscopy. So recognize who's at risk. When you have your patient, before you scope them, look at their age, their ethnicity, their birth country, a variety of things, H. pylori infection, lifestyle factors, particularly smoking, family history, and start to recognize, do I need to be a little bit more attentive to look at, do I biopsy this patient for intestinal metaplasia, and recognize who these patients are. Recognize the endoscopic features of gastric intestinal metaplasia, and in particular, this is important to, again, set your mind to this before you get into the procedure. When you get into the procedure, make sure that you're using the appropriate equipment. This, at minimum, would be high definition white light endoscopy with advanced imaging, narrowband imaging, for example, at minimum. Learn the endoscopic appearance of both white light and the other advanced imaging technique for development of focality for gastric intestinal metaplasia. And then make sure you have adequate visualization, analogous to what we do in the colon. Wash, 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 get all the debris out. If you need to have bubbles removed, use something like a mucosal clearant agent like simethicone. Make sure you adequately distend and insufflate. All the folds get distended. Again, these are really important. And Dr. Shaw makes a point of using a dwell time of 6 to 7 minutes, much like we use for withdrawal times for more is better in the colon, and certainly the same for the stomach. Make sure you adequately describe these in your endoscopic report. Histologic analysis is really predicated on where you got the biopsies from, and photo document these as well. And ensure that the biopsies are obtained using the Sydney protocol. Again, antrum ×3, greater curvature, lesser curvature, incisura, the corpus, again, greater curvature, lesser curvature, and any concerning lesions in separate bottles. Then you go to post-endoscopy, histologic confirmation. You got to talk to your pathologist. Please talk to them about looking at how you can better report these using the Olga and Old Jim criteria. These should be very helpful as far as risk stratification, allows us to better detail these patients if they can be disenrolled versus need to be enrolled in some type of a high-risk discussion and bring them back with some periodicity. Treat H. pylori, obviously that's a no-brainer. If it's positive, document successful eradication. And again, apply this risk-based approach to your identification of intestinal metaplasia and dismiss a lot of these patients with reassurance that they really don't have a higher risk. If you properly biopsied them, you properly identified, you know the endoscopic criteria. Again, don't forget Sydney, and don't forget the Olga criteria for the histopathology. But clearly, I suspect we can all look at ourselves and say, we know we can do better. Intestinal metaplasia is common. We need to up the ante for how we can improve the ultimate surveillance and if disenrollment surveillance in the majority of these patients. Dr. David Johnson, hope you find this helpful next time you face intestinal metaplasia. Thanks again for listening. See you next time.